Okay, it's 12 noon. Good afternoon, everyone. We're going to get started. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We thank and acknowledge the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather.
Okay, I've been asked to reintroduce Mike because apparently the Zoom link was lost. He's been my boss 3 times as program director, head of micro and head of ID. He's been the head of tropical diseases here. And currently he's the PI of GeoSentinel Network, which is a way to understand through travelers how to meet their needs in terms of preventing infectious diseases and how to learn what infectious diseases are circulating around the world. He brings a wealth of expertise in travel medicine, and today he's going to tell us whether or not we want to go get vaccinated to places where we may or may not want to go. So thank you, Michael.
Welcome to all of you on Zoom who I can't see, to the people who actually figured out where this room was, unlike me. This rounds what this is a topic that I think most of you are really never going to have to deal with, except when your sister-in-law asks you about it. So that made the decision to kind of go relatively broad, but necessarily relatively shallow. But there's a lot of science behind a lot of these things, and I'm happy to answer questions that come up at the end if I get through my 100 slides. I put a lot of thanks there because I stole slides from a remarkable number of people for this particular thing. Some of the people you may know. I think a lot of you know Isaac Bogosh. He's the national news, CBC, CTV national news ID expert he gets interviewed all the time. And then the other people, Gilles from the WHO, some people from CATMAT, Public Health Agency of Canada, where I work, and from the CDC. So thanks to all of them. I can present this to you. I put my disclosures here. I don't have any disclosures related to any product. I mentioned that I'm the chair of CATMAT, Committee to Advise on Tropical Medicine Travel for Public Health Agency. But whatever I say here is my opinion, and it's not the opinion of CATMAT, and does not represent any of the discussions that happened within CATMAT. I have to say that. And as Marcel mentioned, I am the PI of GeoSentinel Network, and GeoSentinel Network is funded partly by the GeoSentinel Foundation, and the GeoSentinel Foundation does take some money from industry, including some companies that make some of the products that I'm going to talk about. So I put that in there. Okay, so I was going to do 5 vaccines, but in the interest of time, it's already going to be tough to do 4. So I'm leaving out hepatitis E, but you should know that hepatitis E, there is a new vaccine. It's not exactly a terribly common disease, but we now have a good vaccine against it, should you ever want to know. So I'm going to talk about 2 vaccines which are really meant for the endemic areas, malaria and typhoid. And then I'll talk about a couple of other vaccines, dengue and chikungunya, which are really should be meant for the endemic areas primarily, but probably will have an indication also for travelers. So here we go. This is my impression of funding agencies' response to tropical infectious disease requests. This is what this, and I because they did refuse my my request to do a study on whether tall people get more malaria than short people. Anyway, I think there may be something here, but we'll never know. Okay, malaria, I can't obviously go through a lot of the basics. I think you know, mosquitoes, Anopheles species. The transmission is primarily at night, dusk to dawn. The worst, there are several species, but the one we worry most about is Plasmodium falciparum. It's the one that causes the worst disease and the biggest morbidity and mortality, although there are other species that cause significant morbidity. The 2022, the last year for which we've got the official numbers, about 250 million cases, something like 600,000 deaths. Important to know that almost all the deaths are in Africa, in fact, and the great majority of those are in children. So it's largely, at this point in history, a disease of African children, which is, of course, the main reason why vaccine development has been so terribly slow. The efforts that go into this kind of thing obviously are not the same as when it's a disease that affects largely richer countries. So there are two products that are currently recommended by the WHO, which I'm going to talk about briefly. One of them is known as RTSS, and the other one known as R21. And it's been one of the holy grails to get a vaccine for malaria for many years, and it's just been a very complicated story because this is an organism. It's a protozoan, so much more complicated genetically and life cycle wise compared to bacteria and fungi and all those other boring things. This life cycle is complex. The immune response is very complex. The organism itself is complex. There is no traditional vaccine market for this because, as I mentioned, it's not really a big problem in richer countries, and so there are very few developers of vaccines. Okay, RTSS. What kind of name is that? RT stands for repeat T cell epitope. And it's a fusion antigen, which is made with this particular epitope. It's an epitope which is from what's called the circumsporozoite protein. And I'll talk very briefly about that. But so there's a malarial antigen, and it's fused to hepatitis B surface antigen. So that's RTS, the repeat T cell, and S is for hepatitis B surface antigen. And the other S is because then they put more hepatitis B surface antigen in it. So it's two S's. There's the S fused to the antigen, and then there's more trying to make it more antigenic and turn it into a virus-like particle. And AS01 is a fairly potent adjuvant that's been used to try and elicit an immune response, which has been historically one of the biggest problems, trying to elicit immune response, especially in children. So we've got this recombinant fusion protein vaccine. It's the malarial antigen is actually just a repetitive sequence of 4 amino acids. And just to show how long this has taken, the vaccine was developed in 1986 by GSK. And all this time has been spent trying to find money to do development study, efficacy studies, and get it developed. It's just been a very, very slow process. I cannot go through the whole life cycle of malaria right now. For those of you in the audience who were medical students at McGill and went through Med 1 at McGill, you all know this because you were taught by an excellent parasitology teacher. And if you've forgotten this, I will be angry with you after the talk. The main point, though, does my mouse show up on the Zoom? Like if I do this, can they see the mouse?
Yes.
They can. Okay. All right. So what we're targeting is the sporozoites. The mosquito injects the sporozoites, and there's really only an hour or so before the sporozoites are taken up in the liver. So it's targeting this really short stage where from the mosquito to the liver, trying to catch it before the full life cycle begins. It also has some activity against the infected hepatocytes. So T cell activity, you'll have T cell activity against infected hepatocytes. So you catch it at this stage over here, and it doesn't really have any activity in what we call the blood stage where it multiplies. The notion is if you catch it here, it'll do better, but it's a pretty short target window. For a vaccine used in poor tropical countries, it's pretty tough because it has multiple doses and boosters. But we do have several published clinical trials. The vaccine, this RTSS vaccine, was actually approved by WHO in 2021, and they recommended that it be used for prevention of falciparum malaria in children living in regions with moderate to high transmission. Where does this come from? Come on. All right. So I just very briefly, a little bit of the phase 3 data. This is going back more than 10 years. There was the initial phase 3 study of some 15,000 children, a very young age group, 6 to 12 weeks old to start at first dose, and then a slightly older group, 5 to 17 months at the age of first dose, with a 1-year follow-up of the first 6,000 children. And, without going into detail, you can see the curves at least separated, which is always a good sign. And what you have here is essentially a vaccine efficacy of about 55%. No protection, unfortunately, in this very young age group. So the protection was only in the slightly older children, but still better than nothing. There was a 7-year follow-up that was published in 2016. Not a huge follow-up, but less than 500 kids done in Africa. Now here we had an efficacy of about 35%. Most of the efficacy is in the first 2 years, unfortunately. And by year 4, they had an efficacy of 2%, almost nothing. Over 7 years, efficacy estimated at 4%. So you could say, well, that's not so great. All right. But nevertheless, WHO recommended, they did a pooled analysis of all the studies and recommended that it suggested that it significantly reduced the incidence of severe malaria in implementation areas, and it was recommended. New from this year is an evaluation of the implementation programs. This is the program is implemented in 2019 in Africa. And this was some 600,000 children who received at least 1 dose. 500,000 had received 3 doses. And the conclusion was that among children eligible for 3 vaccine doses, it was associated with a 32% reduction in hospital admission for severe malaria and a 9% reduction in all-cause mortality, excluding injuries. So, you know, not bad, but there's more. So more recently, 2023, there was a second vaccine that was recommended by the WHO. This one was called R21. Actually uses pretty much the same construct as an antigen, a fusion with hepatitis B surface antigen. It doesn't have the additional surface antigen and has a very potent adjuvant known as matrix M, the same adjuvant, by the way, that's in the Novavax COVID vaccine. So a very, very potent antigen trying to get immunity. It actually was approved in several countries in Africa even before the publication of the phase 3 studies based on phase 2 and the initial phase 2 work. That's how eager people are to get something like this out on the market. The efficacy from phase 2 was published back in 2021. And that phase 2 trial had the antigen with 2 different adjuvant doses, and the placebo was a rabies vaccine. And at the 6 months, so short term, it had a 75% roughly efficacy without any serious adverse events recorded. And that's really, you know, again, short term, it looked really quite remarkable, 75% efficacy. And their conclusion was that R21 appears safe and very immunogenic in African children, shows promising high-level efficacy, and they moved on to phase 3. The phase 3 was just published this year, the first phase 3 data, again, out of Africa, where, of course, most of the malaria is. Again, it was a R21 versus rabies as a placebo. They used the lower adjuvant dosing, 5 different African sites. That same older age group, 5 months plus, because again, not a very good efficacy in the youngest children. It's still multiple doses, 3 doses, 4 weeks apart, booster dose at a year. So a complicated regimen for low resource countries. And the primary outcome was protective efficacy. And again, pretty good. We had vaccine efficacy against clinical malaria episodes 1 or more, and we had they did it at seasonal sites and at perennial sites, and it did about 75% efficacy at the seasonal sites. You can't see the perennial sites, but it was a little bit less, 67% or so, if I recall. So the conclusion was well tolerated, high efficacy against clinical malaria in African children, at least for the duration of this study, which was about a year. The limitations, not powered to assess against clinical malaria at any individual site, nor efficacy against mortality or severe malaria across all sites, but still good efficacy against clinical cases. And so the take-home points I would say, for the vaccines we have available is that they are good enough for a disease that causes so much childhood morbidity or mortality. It's good enough. The 2 have never been compared to each other head-to-head, but both vaccines are rolling out across Africa at this time. They do need a lot of doses, booster doses. We don't know that much about long-term durability. We don't know what further booster dosing might be needed. And one thing these vaccines don't do, which has always been something we've hoped for, is to be able to not just protect the children against malaria, but in fact to block transmission of malaria. In this case, if you get malaria despite being vaccinated, it still goes through its full life cycle and is capable of reinfecting mosquitoes and causing ongoing transmission. So what's next? There's been a lot of work looking at malaria blocking vaccines. This is, I think, pretty neat, where you vaccinate the people and they develop antibodies, but the purpose of the antibody is actually the antibody gets sucked up by the mosquito when they bite you, and the purpose is actually to block the development of the parasite in the mosquito. And so to, in fact, protect the community rather than protect the individual who is vaccinated. Always an interesting idea. They showed that it introduced durable and functional activity. It's not protection to the vaccinated patients, it's activity, antibody development that mosquitoes would prevent mosquito transmission. What else? Well, I talked about using the sporozoite protein. In fact, the idea of using whole sporozoites has been around for about 60 years. They do work. The trouble is that they're very difficult to produce. You have to infect the mosquitoes, then you have to dissect the mosquitoes, get the sporozoites out of them, and store them, usually in liquid nitrogen. Not a great way to mass produce a vaccine, but there is progress in the ability to produce this without going through quite so much labor-intensive work, and we'll see where that goes. The other idea is if you have so much trouble getting kids to develop antibody responses to the circumsporozoid protein, maybe you could use a passive immunity with a monoclonal antibody. And this just from this year, 2024, in the spring, showed that, in fact, giving monoclonal antibodies, in fact, is safe and does also provide very good 6-month protection. So I had to put this because this is from the CBC. There's all kinds of jokes I could make about this, but they're all inappropriate. So I won't say anything other than to say that I don't think that's Isaac Bogosh. At least if it is, he looks very different from when I last saw him a couple of months ago. Okay, typhoid. All right, otherwise known as enteric fever. So enteric fever, we use typhoid to refer generally to Salmonella serotype typhi, but we use the illness is more commonly called enteric fever, which includes Salmonella for typhi, what we call typhoid, and paratyphoid. What you need to know is that there's a lot of it, and the highest incidence in the world is generally in South Asia and Southeast Asia, somewhat in Africa. It's transmitted by the consumption of contaminated food or water. A lot of great historical stories about typhoid. And it often presents as a non-localizing febrile illness. So it falls into the differential of fever in a returning traveler. People think of it as a diarrheal disease. It is not a diarrheal disease. It's just a febrile disease for the most part that may or may not have some GI symptoms. And the real problem that we're having these days is increasing multi-drug resistance, antibiotic resistance. So here are some pictures of people getting typhoid. There's more people getting typhoid. That's the well water that they're using. A disease, again, like malaria, mostly children and young adults. Again, this is not because of the pathobiology of the disease. It's more because of the fact that you get exposed multiple times as a child, and eventually you develop at least partial immunity, so the disease becomes less prevalent because most adults in these areas land up having some immunity. Global burden, what are we talking about? Millions of cases. Interestingly, what appears to be a decrease over 30 years or so, which is, you can wave your hands as to why this is happening, but it may be related to improvements around the world in sanitation and hygiene. Millions of cases. In terms of deaths, not as bad as malaria, still some 100 or 200,000, also showing a similar decrease over the years, it would appear. The problem, as I say, multi-drug resistance. So MDR was officially defined as resistance to ampicillin, trimethoprim sulfa, and chloramphenicol. You could say, well, that's just ordinary. That's not even resistant anymore. That's just ordinary. And we have fluoroquinolones, and we have azithromycin, and we have ceftriaxone. So fluoroquinolones in these endemic areas is actually pretty much 100% resistant. In fact, we had a case here from India, if I'm not mistaken, where it was reported as sensitive, and we treated the patient with Cipro because it was reported as sensitive. I won't say who treated the patient, it might have been me, but we failed. And of course, my Indian colleagues, when I said we had a case of fluoroquinolone sensitive typhoid, they laughed at me and they said it's a lab error, and it was a lab error. But at least we have azithro and ceftriaxone. So except that extensively drug resistant. So XDR is now including resistance to third generation cephalosporins is well emerged in parts of South Asia. But we have azithromycin until 2021, where this paper came out looking at the emergence of azithromycin resistance. The key there from that paper is that this is now the only remaining oral drug that we have, and they reported these resistant cases. And it's interesting because it showed that genetically they showed that the resistance had emerged spontaneously multiple times. It's not the distribution of a single clone. And their conclusion was the emergence of pan-oral drug-resistant Salmonella typhi is imminent. That was 2021. And in case you're saying, well, at least we have carbapenems, well, maybe. 2023 reporting now carbapenemase producing Salmonella typhi resistant to essentially everything that we have except maybe colistin. So getting typhoid is like going to Las Vegas, except instead of winning, you lose. Well, actually, you lose in Las Vegas too, I guess. Anyway, it's a lottery. We've got this fantastic burden of cases, and we've got this fantastic burden of resistance. We've had resistance cases in Canada. There's a report from the Toronto Sick Kids of this extensively drug-resistant isolates, of which there have now been several cases. And the percentage in this review here in Pakistan, percentage of XDR, 75%. How are things going on the global antimicrobial resistance front? This is a joke that I can only use for Canadian talks. Nobody else knows what this is. Not good, but always hope. If only there was a way to combat antimicrobial resistance that didn't involve begging, pleading, legislating, enforcing, educating, whining, crying for better stewardship. Apologies to Makeda. I think what she does here is very important. But if there was a better way, oh, wait, there's a vaccine that was developed about 15 years ago, at least, which is still called in 2019 a new tool. Again, the problem is not having a traditional market, not having traditional manufacturers. But this is a great vaccine. It's safe in children. It contains the same antigen as our current vaccines, but it's just conjugated to a protein, tetanus toxoid. One dose can be used in children at 6 months. This is what we have in Canada. We have an IM and an oral vaccine that use the same VI antigen. They're really not great. They have an efficacy of maybe 60% at best. And this vaccine, so here's one of the first studies in Pakistan, 2021, that got published as a phase 3. Couple 100,000 kids vaccinated, and they selected a group to follow them up more longitudinally. 70% of the cases that came out of this trial were XDR, and the vaccine had 95% efficacy in this group. So that's actually pretty bloody amazing. Here's another study that came from Bangladesh, 2021 published. Again, 60,000 kids vaccinated. The placebo was Japanese encephalitis, 85% protection going out to, what is that, a year and a half or so. And the curves still may be separating even at the end of that duration. So that looks great. Nepal, there we go. Vaccine efficacy 81, 82%. So remarkably more effective than the existing vaccines and single dose. And what about long-lasting protection? We have one study out of Africa just came out this year, followed up for 4 years at almost 4.5 years. Intention to treat efficacy 80% at 4 years, way better than the current vaccines that are available. So looking very promising. World Health Organization has recommended it everywhere in endemic areas. And the rollouts have started. There's already 30 million kids vaccinated in Pakistan, 7 million kids in Nepal, rolling out in Africa. And this is really going very well. And I think we can anticipate that this is going to reduce the burden of typhoid. Again, remember, you're vaccinating the people, protecting them, but the fewer people you have infected, the fewer people you have shedding. And the fewer people you have shedding, you have protection of the whole community. What's next? I mentioned that we're vaccinating here only against Salmonella typhi and not paratyphi, but there is a development of a very similar product which will include at least paratyphi A. So hopefully that will also work. as well. So the take-home points for the vaccines in endemic countries is that good enough. I would say malaria vaccines are rolling out and maybe better ones on the way. And we really have an excellent typhoid conjugate vaccine, which is now rolling out, which I think is going to make a very big difference, especially as drug resistance, antibiotics are becoming almost impossible to manage. Antibiotic resistance is becoming impossible to manage in these countries where the only drugs that are available to use are simply not feasible. So I think this is a remarkable change, one of the first big changes that's happened in tropical diseases in endemic areas for a very long time. I'm going to shift now quickly to a couple of vaccines, which although really their major role would be in endemic areas, these are vaccines that are being developed by traditional pharmaceutical companies, and they are being marketed to travelers, which is, of course, where big money is. You're never going to make money selling vaccines in Africa. When I was looking for some pictures, I have to tell you that dengue fever thing. So that's an American band. They do this electronic kind of stuff. They're Cambodian, but they record out of Los Angeles. And I mean, obviously, I was preparing the talk and I had nothing better to do, so I actually listened to this album. Not bad. But anyway, that's not the purpose of the talk. What I want to tell you about dengue is that it's complicated. And it's complicated because dengue is 4 different viruses. It's one disease, but it's 4 really different viruses. Viruses actually only have about 65% homology in their RNA. And so, but it's worse than that. So it's not just that one doesn't protect against the other. It's worse than that. I'll mention this again, but you have this weird thing that happens, whereas if you get dengue once, so you get, say, serotype 1, you develop immunity to serotype 1, but not only are you not protected against the other serotypes, but the other serotypes can then become worse. There's this thing called antibody-dependent enhancement, and getting first dengue may not be so bad, but you have almost maybe in the neighborhood of a doubling of risk for severe complications with your second episode as a result of the immunity to the first infection. So that's something that is a pretty rarity, I think, in our infectious disease world. And so how is that a problem? Well, it maybe serotypes there's only maybe each part of the world has its own serotype. Well, it used to be that way, that each part of the world had their own serotype. So this is a graph which shows how many parts of the world have multiple serotypes. And as you can see from the bottom right, most parts of the dengue endemic world, in fact, now have, through transport, movement of mosquitoes, perhaps, we now have almost all serotypes present in almost all locations. So the risk of secondary infections with worse complications, has become a real problem. And we've seen this in this year, in 2024, with this absolutely astonishing epidemic that's been documented in Brazil, other parts of South America as well. Brazil's healthcare system has been staggered by this absolute massive number of cases, why is hard to know exactly. Climate change affecting the vector and mosquitoes, the El Nino, or you can do all kinds of hand waving, but the fact is that things are changing in such a way that we're seeing these really massive epidemics. So a little bit about dengue fever. In fact, it's asymptomatic. Probably about half of infections are asymptomatic overall. And in most cases of those who are symptomatic, it's a self-limited febrile illness, although it can be self-limited, but still, quote unquote, severe, meaning bad symptoms. Especially, it's been known to cause a lot of myalgias, debilitating myalgias. One of the common nicknames for dengue fever is breakbone fever, and a lot of people talk about their symptoms like they've been, hit by a bus. Actual technical severe dengue. So there's a WHO criteria for what constitutes severe complications, often needing hospitalization, is somewhere in endemic areas, somewhere in the neighborhood of 2 to 5% of those who are symptomatic. And as I mentioned, this phenomenon where the second infection shows this antibody-dependent enhancement phenomenon. What about travelers? I throw a little thing about travelers here. So GeoSentinel, I have our little bit of data here. We see very little complications in travelers, very few. And I could again go through a whole spiel about why that might be. But the fact is that of all our cases of dengue, only 2% had either what are called warning signs or were severe. And in fact, it's less than 1% met the real criteria for severity. And even those who met criteria for severity were not super severe, most of them. We in fact found only a single death in 15 years, and that's in a cohort of about 400,000 returning travelers. Not all with dengue, but of all comers with all kinds of problems. It's not a huge mortality burden among travelers as far as we know. Case fatality rate in endemic areas, somewhere between 0.1 and 1%. Estimated to be somewhere in the tens of thousands of deaths per year. The main risk factors, it's like almost everything, young and old. I don't like this definition of old, but that's another debate. Like I say, we haven't found a lot of cases in travelers. So vaccines. There's a whole bunch of vaccines in development. I'm going to talk about the far right mostly. The first vaccine, CYD-TDV, commercially was known as Dengvaxia, and the more recent TAC-003, commercially known as Qdenga. The other one that's right behind them is the TB-003, sometimes called the NIH vaccine or the Butantan vaccine, and I'll mention that very briefly. What's the problem? The problem is that you're trying to give a vaccine against 4 different viruses. And how do you do that? These are live vaccines, live attenuated. And you need to develop immunity against all 4 types. Because if you don't, you run the risk that you have antibody-dependent enhancement. So if you have immunity against type 1, but not good immunity against type 2, and you get infected with type 2, you could develop more severe disease. And that's always been the fear. So the trick has been trying to find a vaccine that would induce immunity against all 4 serotypes. So the first one, sorry, I didn't label that properly. So the first one is the CYD vaccine. That's actually a yellow fever vaccine that's had a couple of dengue antigens grafted onto it. So it's the actual multiplying vector is yellow fever vaccine with 4 different sets of antigens, recombinant, grafted onto the yellow fever backbone. The TAC vaccine actually tried to use 4 different, tried to use dengue 2 as the backbone. So dengue 2 would be the backbone, except that they would then replace the same 2 antigens from dengue 2 with the other 3 serotypes. But the backbone of it is dengue 2, and that's important because I'll show you that what that's turned out to be is that it's primarily a dengue 2 vaccine, maybe not surprisingly. And then you have the NIH vaccine, which is actually look for different viruses, except the dengue 2, where they had trouble with immunity. So the dengue 2 uses a dengue 4 backbone. Anyway, a lot of complicated stuff there. What's the problem? The problem is, again, everybody being afraid that infection with one particular serotype could cause a problem. And there was a hint of it in the first phase 3 study of the CYD vaccine, post hoc analysis, looking at hospitalizations. And you had this weird thing in year 3. So year 3, and why year 3? Because the idea is that if the vaccine induced immunity well, all 4 types would be, you'd be immune to all 4 types for a long period of time. But if it didn't do so good, what would happen is you would be unprotected against maybe 1 or more serotypes, at risk of severe disease from those serotypes, and that would show up, in a year or 2 when you got exposed to that new serotype. So you don't expect the complications to appear right away. You expect it to appear when you get that particular serotype exposure. And here's this thing where it was noticed that in the kids, at year 3, it's a small number of hospitalizations, but there was this hint that the vaccinated kids did worse. They had an odds ratio of hospitalization, a relative risk of hospitalization of almost 7.5. Admittedly, a small number, but everybody stood up and said, uh-oh, what's that about? And this has to do with what do the analyses tell you, and how are the analyses done, and how are they presented, and how clear is it that they've looked for this particular problem when they produce their data. So the way you look at it is you look by whether the kids are seropositive or seronegative at the time of their first dose. So if they're seropositive, let's say they've already been exposed to dengue before they're vaccinated, then when they get vaccinated, it's like their second exposure. So their second exposure, instead of being a bad dengue, is the vaccine. So that's a good thing. But if you're seronegative when you're first vaccinated, then then the vaccine is like your first infection. And if you're not protected against all the serotypes with that vaccination, you are now at risk that with your second true vaccine exposure, you might have a problem. So we already see that in the seropositive kids, the efficacy is 72%. In the seronegative kids, the efficacy is only 30%. You know, not a shock, but not great. But the real scary thing is the relative risk for severe dengue. And I'm going to blow this up because it was noted that, so in these efficacy studies, you never want to see lines crossing. Doesn't matter what they are. Lines should not cross each other. Crossing is a bad thing. And again, this is just a thing to lay out again. If you're not vaccinated, you're naive, and you then get your first infection, your primary infection, your secondary infection could be worse. If you're vaccinated seronegative, that's like your first infection, and your primary infection becomes secondary-like. And if you're seropositive to start, then you're probably okay. So that's the difference between this group, who are probably okay, and this group, who are at risk of severe dengue when they finally get exposed to the virus for the first time. And I blow up that graph again, and what's going on here? It's a little complicated, but so this is the control seronegative group, and this is the control seropositive group, okay? So it's worse to be a seropositive control, right? Because you're at risk for severe disease by virtue of being seropositive. The dotted lines are the vaccinated group. The vaccinated seronegatives do at least as bad as the controls, and maybe worse. The vaccinated group is doing worse than the control group. The vaccinated seronegatives are doing worse than the control seropositives. So that's exactly what we did not want to see, and it's showing up around 3 years when they're getting cumulative exposure to their first case of dengue. So just to flog a dead horse here, the problem is that this vaccine is primarily a dengue 4 vaccine. That's both by the viremia induced by the vaccine and by the antibodies against that serotype. And so you don't have an equivalent response against all of the serotypes. You've got a strong dengue 4 response and not so great response, especially dengue 2, a particularly bad response to dengue 2, which is exactly what you don't want, especially if there's dengue 2 circulating in your community. So much for that vaccine. That vaccine is actually being withdrawn at this point, as it's been replaced by the TAC-003. TAC-003, interestingly, has been approved not only in several endemic countries, but it's actually been approved for travelers, and I'll come back to that, in Europe. It was rejected by the FDA for lack of data, which I'll show you why, but it's being supposedly considered in Canada, but it is available in most of Europe, by the way, so interesting thing. Outcomes initially looked good, efficacy 80% at year 1, down to 60% a few years later. Safety looks good. This is, remember, this is kids, 20,000 kids in highly endemic areas. And you've got the curves doing what they're supposed to do. You've got the placebo group kind of overlaid up here, and you've got the vaccine group doing okay. You don't have any sense of the vaccine group doing worse than the placebo group, which is considered to be a good thing. In fact, it's not a four virus vaccine as we hoped. It is predominantly, unfortunately, a dengue 2 vaccine. Dengue 2 response does much better than the others, which we don't really like to see. We see that more again in the seronegatives. The seronegatives respond well to dengue 2, less well to the other ones. The seropositives at baseline give a more homogeneous response. So, sorry, this is all complicated, but the seropositives is not a problem. The seropositives have reasonable protection across all serotypes. This is for virologically confirmed disease. The problem is here, dengue 3 and 4. So you got these negative. Now, negative numbers are bad in vaccine efficacy, but huge confidence intervals, because the trouble with the trial was that there was very little dengue 3 or dengue 4 in the trial. So there simply were not enough cases to know. It's not nice to see a point estimate in the negatives. That gives you a bad feeling, but we don't really know because the numbers were so tiny. that was disease. What about hospitalization? So we've got the same issue going on. So for dengue 3 and 4, we've got too few cases to tell. So we got a minus 80% efficacy here. But it's based on 11 and 3 cases. And the dengue 4 is listed as 100% efficacy based on one single case in the control group. The bottom line here is we don't know. We just don't know what happens when you get the TAC-003 vaccine and then you get dengue 3 or dengue 4 infection. We don't know. And that's the main reason why the FDA rejected in the States. The Europeans accepted it. God knows. I mean, the Europeans, we need the Europeans, right? Because it's like there was an antibiotic years ago called trovafloxacin, and it was never approved here, but it was approved in Europe. And we said it had a super broad spectrum: gram negatives, gram positives, and Europeans. And thankfully to the Europeans, we got to know. So again, the Europeans are going to help us here. We're going to see whether they die or not after the vaccine, and that'll be a good thing for us. So the EU statements for how to use the vaccine, this is a kind of summarized, they all have the same general message, but the same general message is actually that you should only vaccinate people with prior dengue. So they recognize this problem in the seronegatives, and they say, don't vaccinate people who never had dengue. We don't know enough. And you have to have real documentation of previous infection. And, risk benefit must be taken into account and so on. So anyway, a lot we don't know. And then quickly, chikungunya vaccine. So chikungunya, this is how you spell it. There's going to be a quiz. So I had to put in some joke here. It's hard to find chikungunya jokes. This is just a dad joke. Hey, bug on my back, are you a mite? I might be. Stupidest pun I ever heard. What do you expect? I just made it up on the fly. Okay, now that you finished laughing, chikungunya. So the problem, here's the countries that have been most recently affected with chikungunya, to give you an idea. It's again, but the real problem with chikungunya is that it tends to occur in epidemics. Endemicity is very low level for the most part, and it occurs in epidemics, and the epidemics can be quite explosive. There was one last year, 2023, in Paraguay. An absolutely massive outbreak in Paraguay, incredible transmission, a lot of hospitalizations, a fair number of deaths. Like usual, deaths clustered largely in the very young and in the very old. So severe cases are rare, but can be overwhelming in these massive outbreaks. Looks like overall, maybe 4% of cases need to be hospitalized. Of at least symptomatic cases, and the severe outcomes go across the board, all kinds of things, including neurologic involvement. And again, like I said, more often in the elderly and people with chronic medical conditions. Deaths occur, but they're pretty rare. And the real issue that we have with chikungunya is the morbidity. And the morbidity that's unique, that's emblematic of chikungunya is arthritis, and the arthritis can be either acute, it can be somewhat chronic, or it can evolve into a more typical rheumatoid arthritis kind of picture that is kind of permanent. And so what people are mostly afraid of is this post-infectious arthritis phenomenon. So there is a vaccine, VLA 1553, approved in the US in 2023, approved in Canada this summer, probably available for distribution before the end of the year. Single dose, live vaccine, live attenuated, single dose, primary schedule, approved for over age of 18. Obviously, it's a live vaccine, so not indicated in immunocompromised people and pregnancy and so on. I have to mention that the brand name here, at least in North America, is IXCHIQ. I don't know who they pay to make these names, but I suppose it serves the purpose, which is nobody's going to forget that name. IXCHIQ. Okay. Phase 3, super cool here. No efficacy studies. No efficacy studies because you can't do it. It's a disease that occurs only in outbreaks. So you can't do an efficacy study. So you have to use a surrogate, and the surrogate is immunogenicity. This is the phase 3 data. It's 3,000 people. the efficacy, how did they decide what the proper efficacy seroconversion levels should be? Well, there were some animal studies, there were epidemiologic correlates, and there was this neat thing where what they did is they showed that it's a live vaccine. So they vaccinated you, waited for your developed immunity, and then vaccinated you again. It's a live vaccine, and showed that on the second time round, you didn't develop any viremia. So at least you were immune to the vaccine for what that's worth. Better than nothing. But the immunogenicity is super high. What are we afraid of? Well, it's a live vaccine, live attenuated vaccine, and we're always afraid in these cases that the chikungunya live vaccine might give you a chikungunya-like illness. And the original reports didn't actually talk about this, but when ACIP, the American Vaccine recommending body, went over things, they made the company go back and reanalyze the adverse event data and present the data not in the usual way, but to talk about what they called chikungunya-like illness, and also talk about prolonged chikungunya-like illness, which is basically symptoms lasting more than 30 days. And the thing is that chikungunya-like illness occurred in 11% of the vaccinees. So that's not what we usually see for vaccines. 11% of the people vaccinated from chikungunya got a kind of chikungunya. That seems awfully high. And worse than that is 1 in 200 got a prolonged disease more than 30 days, with a median of, in fact, 90 days. Now, that's generally not so great either for a vaccine that we're giving on this elective basis, not to mention the basic usual vaccine reactogenicity. So there you see severe chikungunya-like vaccine-associated illness, number needed to harm 64, persistent disease, number needed to harm 220, and chick-like illness, number needed to harm 9. Those are numbers that are much worse than we see for most vaccines. So risk to Canadian travelers outside of outbreaks, the incidence is low, even in these endemic countries, with what we call force of infection, number of infections per year. In the endemic setting, maybe 1 in 1,000 per year. Epidemic settings, maybe 1 in 100 per year. Those numbers are not huge, even in endemic countries. And the intense outbreaks are very difficult to predict. And by the time you know that they're there, they're often half over. They tend to be very explosive. So how do we know where the epidemics are and when they happen? And the answer is we don't. I'm going to skip through this pretty quickly, but these were the models that we used when we were discussing things in CATMAT about how many, this is what we call number needed to travel. There's number needed to harm, this is number needed to travel to get one infection. So depending on the underlying situation, it may be 1,000, 10,000 travelers are needed to get one infection. And then you get into the tens of thousands in some cases for the number of travelers that before you see one persistent infection, which is the things that we worry about. And so the actual group who would really potentially, hypothetically benefit from the vaccine is only this group out here, people going into bad epidemics and people staying for long periods of time, like months. The rest of these people, it's hard to say that the risk-benefit ratio is making sense to give them the vaccine. In the hyper-endemic situation, like we saw in Paraguay, maybe in that, if you knew about it, which we often don't, but if you knew about it, then it would certainly make sense. Then the risk-benefit starts to make sense. So the real thing is that the people who get the worst complications are over 65 years old, and we don't have any data at all whatsoever, anything about what happens giving this vaccine to people over age 60. We do know that being over 60 and having diabetes and cardiac disease and hypertension, these are all risk factors for bad chikungunya. We know that having chronic arthritic symptoms are bad for getting arthritis. And the risk for this is pretty well documented. So we have draft recommendations that are starting to come together. We probably will recommend vaccination when there's a big major outbreak going on, and it may be considered for some other people at high risk, but we're nervous about this, and I don't know where we're going to land finally because of this not knowing where outbreaks are and not having a whole lot of data on there's no data at all in giving this vaccine to travelers. All of the data exists on giving it to essentially children in endemic areas. So That's it. Who should be vaccinated? And the answer is we don't know. But we need to have a better system of figuring out where the epidemics are happening and when they're happening. But probably the targets will be long-term travelers or going into outbreaks, and maybe these high-risk individuals. But again, the caveat is that we just don't know. We don't have a lot of data on these people, but the vaccine is approved and it's going to be distributed, and people are going to be asking about getting this vaccine. There's a new one that's coming out soon. It's right, 10-2, and I'm done.
Good, thank you so much. Go ahead.
Yeah, so my question pertains to the malaria vaccines that we were discussing. With those, have there been any studies that looked at whether pregnant individuals would benefit and whether that could like confer immunity to the fetus and the child?
So far, really, the studies are all about children. Yes, you're right. Malaria in pregnancy is bad. It's bad for the fetus. It's bad for the mother. And the approach up until now in highly endemic areas has actually been to give intermittent drug therapy to the pregnant women. So we give anti-malarial therapy once per trimester, depends on what in different countries, but that's the only approach we have. It's not ideal, but that's been the approach. I suspect as these vaccines, these existing ones and maybe the new ones roll out, that we may start to see some information on pregnancy, but we don't have it yet.
I'll read the question in the chat. Is the worst episode of dengue after the first infection due to some priming of the immune system? I think the serious complications are like cytokine storm. Is that correct?
No. It looks like, I mean, there's a lot of debate about this, but it looks like what happens is the development of non-neutralizing antibodies. So when we talk about an inadequate immune response, we mean that you develop antibodies, but they're non-neutralizing. So they don't prevent cell invasion. And what seems to happen is that these non-neutralizing antibodies actually enhance the invasion of cells, and particularly the endothelial cells. So you seem to have the antibodies actually cause improved invasion of the endovascular system, and that's probably why there are more complications. It is not, in fact, like COVID or that kind of thing. It's a different mechanism.
Okay. Marcel?
I had a question about the malaria blocking vaccine, Michael. As you know, there's a long tradition in infectious diseases of trying to balance the public benefit and the individual benefit. The example of typhoid Mary, who was asymptomatic but was removed from work. So with the blocking and jailed. So with the blocking vaccine, the individual has to incur the potential harm for the public benefit. Have the kind of ethical concerns been vetted, and are there communities who say I'm willing to roll up my sleeve for something that gives me nothing to prevent transmission in the community?
Yeah, well, as I think you know, I can't answer that question. I mean, yes, there does seem to be, so this has gone through ethical clearance, whatever that means, and there are trials. So there is some willingness to accept this idea in these communities with the notion that you are protected indirectly if your whole community has less malaria. I will mention though that a Lyme disease vaccine under development, and it actually works much the same way. It doesn't really protect the individual. It blocks the evolution, the development of the disease of the bacteria in the tick. So it's not the only time this has been brought up, and not only in a low resource country.
Thank you. And then the other question I had was, in the end, you presented a vaccine that was approved through phase 3 trial, sorry, without phase 3 trial, just because of its capacity to hit the surrogate. So I guess the philosophical question going forward is, the reason we went into infectious diseases, there was a new disease every year during our career. So as we discover new diseases, can we vaccinate first and work out the mechanism later, or will we have to have underlying biology to understand what a vaccine is supposed to achieve?
And I suspect at least one answer to that question is the growing acceptance of human challenge studies. So, you know, we have what we have, but human challenge studies are almost the only way to answer in some of these cases. And it is tough to do human challenge studies when you have no treatment. you can say it's a low risk individual, they're young, they're healthy, blah, blah, blah. And there, as you know, there have been plenty of examples of human challenge studies that have gone a little wrong, including malaria vaccines.
The chat, Zika marked a diminution, whatever, decreased from 2015 onwards. Why is that?
Can I just say, I don't know? No, listen, these are, it's amazing that for all of these illnesses that are not super infectious in our temperate climates just don't get as much study as you would like. I mean, the general idea seems to be that as you develop enough of an immune cohort in the population, the epidemic force drops off. And then as you have those people getting older and dying off and new naive people entering the population, you become a setup for a new population. But when you have vector-borne diseases, it's even more complicated by all of the factors that affect the vector. And so these kinds, a lot of these diseases, especially the vector-borne diseases, have proven to be remarkably unpredictable. And we know that dengue, we do know why Zika caused such a massive outbreak in the Americas in 2016. Zika.
Yeah, it entered in Haiti.
Yeah. So the point is, I think the point, the huge outbreak was because it seems to be the almost completely naive population in those areas, and it was imported in through a series of hops. And that the same thing that happened with chikungunya. Chikungunya, there was actually a mutation in the virus that allowed it to be transmitted by Aedes albopictus instead of just Aedes aegypti. Aedes albopictus is an invasive mosquito, came from Asia and is now distributed worldwide. And when it became transmittable by Aedes albopictus, that was enough to also cause a massive outbreak.
Michael, we have 2 minutes left. In a question here, in oncology patients coming from endemic countries that may have to receive immunotherapy, what do you suggest?
Well, for the most part, so most of the diseases I talked about are self-limiting diseases. We don't think there's such a thing as chronic chikungunya, chronic dengue. There are typhoid carriers. I don't think anybody's really looked to see if typhoid can reactivate in a carrier. I haven't really heard about that. Malaria is again, one of those things where you can have a low-level chronic malaria, but we don't really hear much about immune suppression of any sort causing loss of control of existing malaria. And listen, it may be that we just don't have enough of those cases, and that as these therapies become more and more prevalent in low-resource endemic settings, we're going to start learning more things about it, because there's the Venn diagram of use of those therapies and where they're endemic is beginning to cross more and more.
It is 1 o'clock, so we're going to have to close out the round. So there's a few more comments there if you want to look at that, Michael. I'd like to thank everyone for attending the rounds. Thank you. Really great comprehensive lecture. It makes kind of you not really want to travel so much anymore, but other than that, it's all good. Thank you very much for this, Michael, and thanks everyone for joining us.
It's actually just a big ad for go to the gas bank.
Go to the gas, yes. We'll do that. Thanks everyone for joining us.